Chronic Obstructive Pulmonary Disease, or COPD, is a serious and progressive lung condition that makes breathing increasingly difficult over time. It primarily includes two main conditions, emphysema and chronic bronchitis, and is most commonly caused by long-term exposure to irritants like cigarette smoke or air pollution. While COPD cannot be fully cured, early diagnosis combined with proper treatment and lifestyle changes can significantly slow its progression and help patients maintain a better quality of life. In this presentation, we'll explore the key aspects of COPD, from its causes and symptoms to the latest management strategies. To understand COPD, we need to look at how lung function is measured. Spirometry tests assess two critical values: FEV1, which is the amount of air you can forcefully exhale in 1 second, and FVC, the total volume of air you can exhale after a deep breath. In healthy lungs, the ratio of FEV1 to FVC is above 70%. However, in COPD, this ratio drops below 70%, indicating significant airflow obstruction. Think of it like a narrow hallway, once wide and easy to pass through, now clogged and difficult to navigate. COPD is not just about blocked airways. It's a complex disease with multiple components. Chronic bronchitis involves inflamed and mucus-clogged airways, leading to persistent coughing. Emphysema, on the other hand, damages the delicate air sacs in the lungs, reducing their ability to exchange oxygen. While smoking is the leading cause, factors like air pollution and genetic conditions such as alpha-1 antitrypsin deficiency also contribute. Understanding these different aspects helps us tailor treatments more effectively. Recent research shows that COPD is more than just a spirometry reading. Many patients experience symptoms like chronic cough, shortness of breath, or visible lung damage on scans before their breathing tests show severe abnormalities. This means we need to look at the bigger picture: environmental exposures, symptoms, imaging results, and lung function to diagnose and treat COPD early. Waiting for severe airflow limitation means missing opportunities to intervene sooner. The pathogenesis of COPD, how damage occurs. Imagine your lungs as a finely tuned machine. When exposed to cigarette smoke or pollutants over time, the lungs respond with chronic inflammation. Immune cells release enzymes that break down lung tissue, leading to scarring, mucus overproduction, and loss of elasticity. The lungs struggle to repair themselves, and the damage becomes irreversible. This process explains why quitting smoking early is so critical. It stops the cycle of destruction before it's too late. Inflammation and oxidative stress. The silent destroyers. In COPD, inflammation and oxidative stress act like a slow-burning fire inside the lungs. Harmful chemicals from smoke inactivate protective proteins, making lung tissue more vulnerable to damage. Immune cells, particularly neutrophils and macrophages, release enzymes that further degrade lung structure. Over time, this creates a vicious cycle. More inflammation leads to more damage, which in turn fuels even more inflammation. Breaking this cycle is a key goal of modern COPD treatments. Cell death and failed repair. Why COPD progresses? Unlike some organs, the lungs have a limited ability to regenerate. In COPD, toxins from smoke accelerate cell death while also impairing the body's repair mechanisms. This means that once lung tissue is lost, it cannot be fully restored. Some researchers even describe emphysema as premature aging of the lungs. Understanding this helps explain why prevention and early treatment are so important. Once the damage is done, we can only manage, not reverse, the condition. COPD pathology. 3 key areas of damage. COPD affects the lungs in 3 major ways. First, the large airways become inflamed and clogged with mucus, leading to chronic bronchitis. Second, the small airways thicken and narrow, increasing resistance to airflow. Finally, the air sacs themselves are destroyed, reducing the lungs' ability to absorb oxygen. Each of these changes contributes to the shortness of breath and fatigue that COPD patients experience daily. Pathophysiology. How COPD affects breathing. In COPD, airflow obstruction is just the beginning. The lungs also trap air, leading to hyperinflation, a feeling of constant breathlessness. Gas exchange becomes inefficient, causing low oxygen and high carbon dioxide levels in the blood. Unlike asthma, where airways can reopen with medication, COPD's damage is largely permanent. This is why treatments focus on relieving symptoms and preventing further decline rather than offering a complete fix. Chronic bronchitis, the mucus problem. Chronic bronchitis turns the airways into a clogged pipe. Normally, cilia, tiny hair-like structures, sweep mucus out of the lungs. But in COPD, smoke paralyzes these cilia while also triggering excessive mucus production. The result? A persistent, phlegmy cough and frequent infections. Over time, this cycle leads to worsening lung function and a significant decline in quality of life. Emphysema, the destruction of air sacs. Emphysema is like a balloon that has lost its stretch. The walls of the air sacs break down, creating large, inefficient spaces instead of the tiny, grape-like clusters needed for oxygen exchange. This reduces the lung's ability to absorb oxygen and expel carbon dioxide. Patients often develop a barrel chest as the lungs hyperinflate, and everyday activities become exhausting due to low oxygen levels. Key mechanisms of emphysema. Why tissue breaks down. Emphysema occurs when the balance between protective and destructive forces in the lungs is disrupted. Normally, enzymes like elasticity help remodel lung tissue, but their activity is kept in check by inhibitors like alpha-1 antitrypsin. In smokers, this balance is lost, elasticity runs rampant, chewing up lung tissue faster than it can be repaired. This explains why some people develop severe emphysema even at a young age, especially if they have genetic risk factors. Types of emphysema, different patterns of damage. Not all emphysema is the same. Central lobular emphysema, the most common type in smokers, starts near the bronchioles and is worse in the upper lungs. Panlobular emphysema, often seen in alpha-1 antitrypsin deficiency, affects the entire air sac uniformly. Paraseptal emphysema occurs near the lung edges and can lead to lung collapse in severe cases. Recognizing these patterns helps guide treatment decisions. Consequences of emphysema, beyond shortness of breath. Emphysema doesn't just make breathing difficult, it triggers a cascade of problems. Trapped air overinflates the lungs, flattening the diaphragm and making it harder to take deep breaths. Low oxygen levels strain the heart, leading to pulmonary hypertension and even heart failure. This is why managing COPD requires a holistic approach. Treating the lungs alone isn't enough. Consequences of hyperinflation in COPD. When lungs become hyperinflated in COPD, it's like trying to breathe with a flattened balloon. The diaphragm loses its dome shape and can't generate proper suction. Patients must use extra energy just to take each breath, often relying on neck and chest muscles. This explains why simple tasks become exhausting. Their breathing machinery is working at a mechanical disadvantage. Gas exchange. In COPD, patterns and implications. The gas exchange problems in COPD create a frustrating paradox. Some areas of the lungs receive air but no blood flow, while others have blood flow but blocked airways. This mismatch means oxygen can't get in, and carbon dioxide can't get out efficiently. Surprisingly, oxygen levels may remain normal until late-stage disease, which is why many patients don't realize how impaired their lungs are until significant damage has occurred. Risk factors for COPD: cigarette smoking. The relationship between smoking and COPD is dose-dependent and frighteningly consistent. For every pack year of smoking, that's 1 pack per day for 1 year, lung function declines. The graph shows clearly. Non-smokers maintain stable lung function with age, while smokers experience accelerated decline. But here's the good news. Quitting at any point slows this progression. Risk factors beyond cigarette smoking. While smoking dominates the COPD story, other risks deserve attention. Occupational dusts, biomass fuel exposure, childhood pneumonia, and even asthma can set the stage for COPD. In developing nations, indoor cooking fires expose millions of women to smoke equivalent to heavy cigarette use. This broad risk profile means COPD isn't just a smoker's disease. Alpha-1 antitrypsin deficiency provides a powerful example of genetics meeting environment. This protective protein normally inhibits lung-destroying enzymes. In deficient individuals, especially smokers, unchecked enzyme activity causes early-onset emphysema, often appearing in their 40s. Genetic testing can identify at-risk individuals before irreversible damage occurs. Other genetic factors. In COPD, modern genetics has revealed over 80 DNA regions linked to COPD risk. Some affect lung development, others influence inflammation or antioxidant defenses. The HHIP gene, for instance, appears crucial for lung repair. While we can't yet change genetics, this knowledge helps identify high-risk individuals and may lead to personalized treatments. Natural history of COPD. Tracking lung function. The life story of lungs follows 4 chapters: growth in youth, stability in early adulthood, gradual age-related decline, and in COPD, accelerated deterioration. Critical periods exist. Poor childhood lung growth or early smoking can permanently lower the starting point. The takeaway? Protecting lung health is a lifetime commitment. Patterns of COPD progression. COPD doesn't develop identically in everyone. Some experience reduced lung growth in childhood, others normal growth but rapid decline. Surprisingly, many COPD patients show normal decline rates. Their problem was never reaching normal peak function. This complexity explains why some non-smokers develop COPD, while some heavy smokers don't. COPD typically progresses through stable periods punctuated by exacerbations, sudden symptom worsenings often triggered by infections. Each exacerbation causes lasting harm, like a forest fire leaving permanent scars. Systemic effects emerge too: muscle wasting, osteoporosis, even heart disease, proving COPD is truly a whole-body illness. Clinical presentation. Key symptoms. The COPD symptom. Quartet, cough, sputum, breathlessness, and activity limitation often develops insidiously. Patients frequently dismiss early symptoms as smoker's cough or aging. By the time walking upstairs becomes difficult, significant lung damage has usually occurred. This delayed recognition is why we must proactively screen at-risk individuals. Physical exam findings in COPD. Exam findings evolve with disease severity. Early COPD may show only subtle signs like mild wheezing. Moderate disease brings prolonged exhalation and barrel chest. Advanced cases reveal dramatic signs: pursed lip breathing, accessory muscle use, even paradoxical rib movements. Yet physical exam alone can't reliably stage COPD. Objective testing remains essential. Laboratory findings. In COPD, spirometry provides the diagnostic cornerstone, showing obstructed airflow. As COPD advances, blood gases may reveal low oxygen and high carbon dioxide. Imaging shows hyperinflation, flattened diaphragms, and an emphysema, bullae. Alpha-1 testing should be routine, identifying deficiency changes management and alerts family members to their risk. Gold criteria for severity. The GOLD system classifies COPD severity from stage 1 or mild to stage 4 or very severe based on spirometry. But numbers alone don't tell the whole story. A stage 2 patient with frequent exacerbations may need more aggressive treatment than a stable stage 3 patient. This is why we now combine spirometry with symptom and exacerbation assessments. Beyond FEV1, multidimensional assessment. The BODE index revolutionized COPD evaluation by looking beyond lung function. It considers body mass, airflow obstruction, dyspnea, and exercise capacity, together predicting survival better than FEV1 alone. Modern GOLD assessments similarly incorporate symptoms and exacerbation history, recognizing that COPD's impact varies widely between individuals. Current GOLD guidelines categorize patients based on both symptoms and exacerbation risk. Group A has few symptoms and low risk, while Group D has both high symptoms and high risk. This classification guides therapy from simple bronchodilators in mild cases to combination inhalers and rehabilitation in advanced disease. It's a more personalized approach to COPD management. Treatment goals for COPD. Our treatment aims are both ambitious and practical. Reduce mortality, slow progression, prevent exacerbations, improve exercise tolerance, and relieve symptoms. While we can't yet cure COPD, modern therapies can achieve all these goals to varying degrees. The key is matching treatment intensity to disease severity and individual patient needs. Interventions that improve survival. 3 interventions definitively prolong life in COPD: smoking cessation, oxygen therapy for chronic hypoxemia, and lung volume reduction surgery in selected emphysema patients. Remarkably, smoking cessation even in advanced COPD provides measurable survival benefit. These aren't just treatments, they're lifelines. Pharmacotherapy, bronchodilators. Bronchodilators remain the foundation of COPD treatment. Muscarinic antagonists like tiotropium and beta agonists like salmeterol work through different mechanisms to open airways. Combining these classes often provides greater benefit than either alone. While they don't reverse lung damage, they reliably improve symptoms and quality of life. Corticosteroids and other agents. Inhaled corticosteroids help prevent exacerbations in certain patients, particularly those with eosinophilic inflammation. Oral steroids should be reserved for acute exacerbations due to severe side effects. Newer agents like roflumilast target specific inflammatory pathways, offering alternatives for patients with frequent flare-ups. Medication therapy. Based on GOLD categories. Treatment escalates logically by GOLD group. Group A starts with bronchodilators as needed. Group B uses long-acting bronchodilators daily. Group C adds anti-inflammatory therapy if exacerbations persist. Group D often requires triple therapy, combining long-acting bronchodilators with inhaled steroids. This stepwise approach balances benefits and risks. Antibiotics in COPD management. While antibiotics don't help stable COPD, they're crucial for exacerbations with increased sputum purulence. Remarkably, chronic azithromycin therapy can prevent exacerbations in select patients, likely through both antimicrobial and anti-inflammatory effects. However, we must balance this benefit against antibiotic resistance concerns. Oxygen therapy in COPD. Supplemental oxygen is life-changing for hypoxemic COPD patients, improving survival when used at least 15 hours daily. It's the only therapy shown to reverse pulmonary hypertension in COPD. New evidence suggests conservative oxygen targets that is 88 to 92% saturation may be safer during acute exacerbations. Weekly IV infusions of purified alpha-1 antitrypsin can slow emphysema progression. While expensive, this targeted therapy exemplifies precision medicine in COPD. It's most effective when started before severe lung damage occurs, highlighting the value of early diagnosis. Non-pharmacologic therapies. Vaccination. Vaccinations are simple but powerful COPD interventions. Annual influenza vaccines prevent exacerbations, while pneumococcal vaccines reduce pneumonia risk. COVID-19 vaccination is equally crucial, given COPD patients' vulnerability. These preventive measures are among our most cost-effective strategies. Pulmonary rehabilitation. Pulmonary rehabilitation is transformative, improving endurance, reducing dyspnea, and enhancing quality of life. Combining exercise training with education and psychological support, it empowers patients to break the cycle of inactivity and breathlessness. The benefits often exceed those from medications alone. Surgical interventions, LVRS. Lung volume. Reduction surgery removes the most damaged emphysematous tissue, allowing remaining lung to function better. Carefully selected patients, typically those with upper lobe disease and low exercise capacity, gain significant improvements in breathing and survival. New bronchoscopic techniques offer less invasive alternatives. Lung transplantation for COPD. For end-stage COPD, transplantation offers a second chance. While outcomes have improved, challenges remain. Donor shortages, rejection risks, and the need for lifelong immunosuppression. Careful patient selection is crucial, prioritizing those with high disability but otherwise good health. Exacerbations are COPD's stormy periods, sudden symptom worsenings that often require hospitalization. Each event accelerates lung function decline and increases mortality risk. Preventing exacerbations isn't just about comfort, it's about preserving lung function and life expectancy. Precipitating causes of exacerbations. About half of exacerbations stem from bacterial infections, a third from viruses, and the rest from pollution or unknown triggers. New research shows that acquiring new bacterial strains, not just overall colonization, predicts exacerbation risk. This explains why antibiotics help even when bacteria are normally present. Assessing COPD exacerbations. Evaluating exacerbations requires looking beyond symptoms. We assess severity through vital signs, mental status, and blood gases. Hospitalization decisions consider respiratory acidosis, hypoxemia, and comorbidities. The goal is to intervene early enough to prevent respiratory failure. Treating exacerbations, bronchodilators. During exacerbations, we intensify bronchodilator therapy, often using nebulizers initially for severe cases. While these medications don't reverse the underlying inflammation, they provide crucial symptomatic relief by reducing airway constriction and air trapping. Antibiotics for COPD exacerbations. Antibiotics shorten exacerbation duration and reduce treatment failure rates when sputum becomes purulent. Choice should consider local resistance patterns and patient risk factors. Short courses that mean 5 to 7 days are usually sufficient, minimizing side effects and resistance development. Systemic glucocorticoids in exacerbations. Oral steroids speed recovery from exacerbations, reducing relapse risk. However, we now use shorter courses than previously. That means 5 days at lower doses. That means 30 to 40 milligram prednisone, balancing benefits against risks like hyperglycemia and muscle weakness. Oxygen therapy. During exacerbations, we target oxygen saturations of 88 to 92% in COPD patients, enough to correct hypoxia, but avoiding complete oxygen saturation that could worsen carbon dioxide retention. Careful monitoring is essential as needs can change rapidly. Non-invasive ventilation for exacerbations. Non-invasive ventilation has revolutionized exacerbation management, reducing intubation needs and mortality. By assisting weakened respiratory muscles, it buys time for medications to work. Contraindications include impaired consciousness or inability to protect the airway. Invasive mechanical ventilation. When non-invasive methods fail or contraindications exist, intubation becomes necessary. We use lung protective strategies to avoid further injury, accepting higher carbon dioxide levels if needed to prevent ventilator-induced damage. Even with best care, hospital mortality remains significant. Post-exacerbation outcomes. The aftermath of exacerbations is sobering. 20% readmitted within 30 days, 45% within a year. This high recidivism underscores the need for thorough discharge planning, including medication optimization, rehab referrals, and close follow-up. COPD in India. Epidemiology and burden. India's COPD burden is massive, 37 million cases nationwide, with prevalence varying regionally. As the second leading cause of death, it claims over 8% of lives annually. Unique risk factors like biomass fuel use and high tuberculosis rates contribute to this disproportionate impact. Risk factors for COPD in India. In India, tobacco comes in many forms like bittis, hookahs, and chewing tobacco alongside cigarettes. Rural women face particular risk from indoor biomass cooking fires. Occupational exposures in mining and textiles compound these risks, creating multiple pathways to lung damage. Diagnostic challenges. In India, Limited spirometry. Access in rural areas means many cases go undiagnosed or misdiagnosed as asthma or TB. Cultural acceptance of breathlessness as normal aging delays care seeking. Improving diagnostic capacity at the primary care level is crucial for earlier intervention. Management strategies for India. India's approach combines prevention, like clean cookstove initiatives, with task-shifting diagnostics to frontline workers. The NPCDCS program integrates COPD care into chronic disease management, while Ujjwala's LPG subsidies aim to reduce biomass exposure. These population-level strategies complement individual treatments. Economic impact of COPD in India. COPD's economic toll is staggering. $470 annual direct costs per patient in a country where most healthcare is out of pocket. Indirect costs from lost productivity triple this burden. For many families, COPD means medical impoverishment, choosing between treatment and basic necessities. Global comparison of COPD burden. While India's 8.7% COPD prevalence is below the global 11.7% average, its absolute numbers are among the world's highest. Developed nations see smoking-driven COPD. Developing countries face more biomass and occupational exposures. These differences demand tailored prevention strategies. Future directions in COPD research. Precision medicine may identify responders to specific therapies, while regenerative approaches aim to repair damaged lung tissue. Novel anti-inflammatories target specific pathways, and AI could predict exacerbations before symptoms appear. After decades of limited advances, COPD research is entering an exciting phase. Emerging therapies for COPD. Drugs include targeted anti-inflammatories, new mucolytics, and antioxidant approaches. Some aim to rebalance protease antiprotease systems. Others target cellular senescence. The challenge will be matching these advanced therapies to the right patient subgroups. Digital health in COPD management. Wearables and telehealth are transforming COPD care. Remote monitoring detects exacerbations earlier, while virtual rehab improves access. During COVID-19, these technologies proved their value. Now they're becoming standard tools for chronic disease management. COPD and comorbidities. COPD rarely travels alone. Cardiovascular disease, osteoporosis, depression, and lung cancer are frequent companions. This comorbidity burden explains why COPD patients often take 10-plus medications. Comprehensive care must address these systemic impacts, not just lung symptoms. Patient education and self-management. Empowered patients do better. Teaching proper inhaler technique, exacerbation recognition, and energy conservation techniques reduces hospitalizations. Action plans that guide patients when symptoms worsen are particularly effective, especially with professional support. Palliative care in advanced COPD. Palliative care remains underused in COPD, despite symptom burdens matching cancer. Opioids carefully titrated can relieve refractory dyspnea without dangerous respiratory depression. Early palliative integration improves quality of life while continuing active treatments. Public health approaches to COPD prevention. Population-level interventions like tobacco taxes, clean air policies, occupational protections, etc., prevent more COPD than any clinical intervention. India's tobacco control programs and clean fuel initiatives exemplify how policy changes can shift disease trajectories at scale. The COPD landscape is evolving, from spirometry alone diagnosis to multidimensional assessment, from one-size-fits-all treatment to personalized approaches. Early detection, comprehensive care, addressing comorbidities, and global prevention strategies offer hope against this debilitating disease. Thank you for your time and attention as we explored the complexities of chronic obstructive pulmonary disease. Together, we've examined its causes, progression, and management strategies, highlighting the importance of early intervention, personalized care, and global prevention efforts. Let's continue working towards better outcomes for COPD patients through awareness, research, and compassionate care. Thank you.